everyone here this morning, but we need to get started. So it's our pleasure this morning for University Brands to host the Palmer Lecture, and she will be introduced shortly by Haya Schwartz. But to begin with, I would like to acknowledge the land upon which we're meeting today and upon which the University of Toronto operates. It was for thousands of years the traditional homeland of many Indigenous peoples, some of which include the Haudenosaunee, the Anishinaabeg, the Huron-Wendat, and the Mississaugas of the Credit. Many Indigenous peoples continue to make Toronto and environs their home, and we acknowledge the historical injustice done to their ancestors and to them in this continuing day, and seek to do better in our relationships with them and with the land. Next, I'm going to bring up one of our most coveted senior surgeons to speak a little bit about John Palmer and why we named this lecture after him. Lauren Rothstein.
Thank you. Thank you, Dr. Swallow. I think that was a little bit tongue-in-cheek, though. Anyway, I've been doing this eulogy every year since 1985, and as time passes, there are fewer and fewer of us who knew or remember John Palmer. Let me try to provide a few thoughts about him. John Palmer was born in Meaford, Ontario in 1925. He attended medical school at the University of Toronto and then completed the then Galley course in general and in plastic surgery in Toronto. He was double boarded. After obtaining his Royal College fellowships, he was awarded a prestigious Newfield Scholarship to do fellowship training in reconstructive surgery at the University of Edinburgh. And after that, he went and did colorectal surgical training at St. Mark's. He then returned to Toronto as what we would now call a surgical oncologist. He referred to himself as a head and tail surgeon. He developed an interest and expertise in a broad range of general surgery and head and neck reconstruction, thyroid, parathyroid, GI malignancy, skin cancer, melanoma, perianal malignancy, and radiation enteritis. He was also interested in sports medicine and was team doctor for the Toronto Argonauts. He took me to their training camp to do examinations, and I clearly remember standing there with a stethoscope up like this, trying to reach high enough. I still couldn't make it. He did not publish prolifically, but what he did publish was pivotal, particularly his work on radiation enteritis and the GI tract related to external beam radiation, and his work on primary hyperparathyroidism, which I still refer back to today. He was a master surgeon. In essence, he was a surgical poet in an age of prose. How's that? He was a thoughtful clinician, a gifted teacher, and I personally had the privilege of training with him. It was an enriching experience, a highlight of my residency. He was an iconoclast. He didn't like rules. If there was one, he broke it. If there was a policy, he ignored it. He was great at being passive aggressive in dealing with hospital administration and senior staff, program directors, department chairs, and so on. Anyway, he had numerous and eclectic interests. Could I have the next slide, please? I can press it. Oh yeah. Oh yeah.
Yes, sir.
Which one? Okay. He had many interests outside of surgery, particularly his family. He was a painter. He collected art, collected antiques, restored antiques, classic cars, which he worked on, and he carved decoys. He taught anatomy in his spare time. He was an avid skier, a boater. He lived a balanced lifestyle in an era when being a workaholic was the norm for most surgeons. He was a quiet and gentle man, very much a private person. He would have never blew his own horn, and he would have been embarrassed, or actually would have hated my talking about him like this. He died prematurely in 1984 of ironically malignant disease. He is survived by his daughters, Valerie, Marilyn, and Jennifer. This lectureship was established by his friends, family, and former students and his medical colleagues in 1985 as a tribute to his life and to his memory. This is one of his paintings. It's the kind of work that he did when he wasn't operating. So thank you.
Thank you very much, Lauren, for that perspective. Makes the lecture even more meaningful. And next, to introduce our visiting professor, we're going to hear from one of our junior colleagues in HPB at Toronto General, Haya Schwartz. Welcome, Haya.
Thank you. I'm not that young, but thank you. So I'm very happy to present Dr. Minter. On a personal level, she's always so open for, to go for advice, for mentorship on the educational societies and educational milieu. She's such everyone knows her and know of her. And we're so thankful for you to come here to Toronto. So Dr. Minter, your CV is so long and I had to summarize it a little bit, but Dr. Minter is a Curreri Professor and Chair of Department of Surgery at the University of Wisconsin. She's also previously held the successive leadership roles at the University of Texas Southwestern and the University of Michigan, serves as the Chief of HPB divisions, which is extremely impressive, especially for a female in our field. Dr. Minter's clinical practice is in the area of HPB surgery. She has a very, very special interest and knowledge on the benign diseases of the pancreas, as well as cancer of the pancreas. She is recognized as a clinical leader in our field of HPB. She was also the past president of the HPBA. She's also the diversity and inclusion officer of the HPBA. So very, very impressive on the clinical side. On her research efforts, she focused on surgical education. There's a lot of educators now here in the room that came to see her as well. She's a very specialty in development of training frameworks, which explicitly define progressive entrustments and the development of autonomy, which we're going to hear about some of it now. Dr. Minter holds national leadership positions in multiple societies and recognition of her work in the field of surgical education and academic surgery. She's the past president of the Society of University Surgeons and Fellowship Council, and currently serves as the vice chair of the American Board of Surgery Board of Directors. So I know all of this is very, very impressive for the clinical work and the research work, but what was really, really impressive for me is that when I asked one of your trainees and also one of our friends, a good mutual friend, how would you define Rebecca? And what our friend said, she's just amazing. She's thoughtful and inspiring leader. She speaks up for what she believes in, that is right, supports the people under her. She's a role model and lead by example, always thinking of people, concerned for their well-being, a true educator and an educational leader. She's clear about priorities and also includes her family and friends. She's just the best. And then your trainee said, she's just incredibly thoughtful, smart leader who also maintains her own humanity. She somehow seems to do it all. I don't know how she does it. A surgeon, a mother, a partner. So I think that says it all. Thank you for coming.
Well, thank you for that incredibly kind introduction and those kind words. I'm going to have to get those from you later when I'm having a bad day, because that was really very unexpected. So I'm was just so thrilled to get the invitation to come back to Toronto, and wanted to say thank you to Dr. Swallow, who I haven't had a chance to get to work with very much thus far, beyond our email chain that we have for the Society of Surgical Chairs of all of the women chairs. But I just have to say, I've heard such amazing things about you from so many people, and I look forward to getting a chance to work more closely with you through the Society of Surgical Chairs, and to Dr. Jackson as well for the invitation. And incredible dinner last night where I got to meet more wonderful people from the University of Toronto. I could not put everyone on this slide, but I wanted to give a shout out to the younger people in the room to just say, Paul had me come out probably 8 or 9 years ago. I had a catch your title then, was Would I Trust You to Do My Whipple? And, but of so many people here, you know, through the HPBA and the societies, I've just had such the privilege of getting to know so many incredible people from here. I think that the women should tell the men it's actually okay to smile for your photograph. I didn't look up Dr. Wong's, but I bet he's smiling in his photograph. But just, you know, I have learned so much from the people on this slide. And when I was here last time, I got to spend time with Carol Ann at the Wilson Center and just hear the incredible work that was happening. And Dr. Lalaldra is one of our transplant faculty, and we're just absolutely thrilled that one of your current fellows, Dr. Aker, will be coming to the University of Wisconsin next year to be one of our surgical oncology faculty. So lots of great connections over many, many years. And I think one of the things that's so incredible about academic medicine are the friendships and the relationships that we make and the people you can call for advice and guidance, sometimes outside of your own institution, which is just so incredibly valuable. So deep gratitude and feel really such warm things for the University of Toronto colleagues. As was mentioned, I am a board director for the American Board of Surgery. And while I'm going to talk a lot today about things that we are, what I would say, translating and implementing through the American Board of Surgery related to sort of the work that I've been connected to for a long time, these views are my own and don't specifically represent any official positions of the ABS. I am, however, super excited about where things are headed. And it's really, I think, incredible to see this actually happening in my career, because a lot of times we work really hard at things and you sort of iteratively move things forward, but there's been kind of a big leap forward of these concepts in a way that I think is going to be really impactful in my lifetime. And so it's very exciting to see that. And so related to that, and I was looking back to see, gosh, what did we talk about when I was here 8 or 9 years ago? I became a little philosophical, and so wanted to just share some, I think, threads and ideas for the young people in the room to think about. And as Haya mentioned, my scholarship focus has been in surgical education, but my career did not start there. I've always had a deep passion and interest in this going back to residency, this concept of, gosh, it seems like our training paradigms aren't quite right. Like I loved my training, but there were some pieces of it that needed to look different. This concept of competency-based training paradigms has been a thread all the way through my career, but I was also running the basic science lab and doing the more traditional academic surgery things. But the problem that kept coming back that, you know, I'd like to think about after hours, that I would be willing to work on after hours, was this idea of how do we develop a better training model for surgeons. And so I think as you dive into whatever you want to focus on, make sure that the problem you're very clear about and make sure it's big enough to sustain you over a career. A lot of times when I meet with young faculty, they're like, well, I want to do a survey, or I want to do this little thing or that little thing, or they're like, tell me, what's your goal? I want to get an R01. I'm like, well, that's not very inspirational. Like, I would love for you to get an R01, but tell me, you know, tell me you want to cure cancer, right? Tell me you want to fix, you know, this big problem. It needs to be a big problem. Otherwise, you're not going to stay connected to it, and it will evolve over the course of your career. And then find really, really smart people and then listen to their ideas and be open to thinking about things differently. And a lot of those smart people are here in the room. Stan Hamster's here. I had an opportunity to collaborate with him when we were on faculty together at the University of Michigan. I mentioned Carol Ann. So many colleagues. Gurjit Sandhu, I was fortunate to recruit to the University of Michigan when I was there, who had been at King's University, who came with really the experience of really deeply understanding kind of the competence by design concepts that had been rolling out, and was able to partner with her to develop what I talked about the last time I was here, which was a faculty and resident development tool called OpTrust, which was really a tool to understand how do we interact in the operating room between trainee and faculty member, and how do we move people along in those interactions. And so then we figured out that, gosh, like, this is really about the human-human interaction. So then we worked with an executive coach to develop the tool and to think about how do we help coach people to understand themselves, but then understand the interaction. Is sort of in the operating room, we all know it. if it's the quote, the dance where everything's perfectly orchestrated, you don't even have to talk and you're totally in sync, or it's like a complete and utter struggle. And that tone is set usually, 30 minutes into the operating room. And so we're able to study that and then figure out how do we make that better, smoother. So to that end, when you have this really big idea, you have to sort of, what I would say, chunk it, because you start to feel totally overwhelmed. Well, how am I going to cure cancer, right? Like there's a lot of steps upstream of that. And so you have to sort of say, I want this to be the end point, but what are all the pieces along the way? And so the work we did with Dr. Hamstra, the ultimate endpoint is how do you translate our training paradigms into outcomes for patients? So that's not my area of focus, but there's a whole bunch of people now who are working on that. Bridget Smith, who we recruited recently to our faculty, is really probably the leader in that space, and there's a lot of people thinking about that. So if you're really thoughtful about the problem, and then you can create your roadmap and chunk it into the pieces that really are impactful, and then take on their own threads as others lean in and are excited about the idea as well. And then I think, you have to not give up. So you're going to bump into multiple walls and have many, many barriers. And I always say my superpower is persistence. And when you hit the wall, you figure out the way around, and then you hit the next wall and you go this way. It is not a straight path. It is very much a curvy road. And I think you just have to be persistent, but flexible, because if you're too rigid, you're like, well, this is where we need to go, and it's from here to here, then you'll get stuck and you'll get very frustrated and give up. And this concept I'm going to touch on again in later in the talk, but this concept of being the first mover or the fast follower came out of the business literature, actually. And again, back to that, find a lot of smart people who think about things differently and figure out how to bring that thinking into your work is a really interesting one. And I would say we've really benefited from being the fast follower in the work that we're going to talk about, really following on the heels of the work that's been done in Canada. And then again, adapt, respond, keep moving forward. So it's never going to look exactly like you thought it did, but it's probably hopefully going to look better if you're really willing to integrate the information and the things that you learn from others, or where you fail, because you never get it exactly right out of the gate. So for me, and I would say now more globally for us as a community, the problem really sort of fell into four areas. I think in general, there's a lot of dissatisfaction with our current assessment systems, whether you talk to the trainees or you talk to the faculty, the kind of end of rotation evaluation system where you're like, trying to provide feedback that's helpful just really doesn't work. Everybody hates it, and it rarely yields useful feedback. The competency framework was meant to address that, but it unfortunately, in its initial sort of rollout, really just led to relabeling of that end of rotation evaluation in the language of the competencies. And now we were asked, in addition to the end of rotation evaluation, like, how are they in systems-based practice? How are they in learning, improvement? And it was unfortunately not as successful at its rollout as we would have hoped. The milestones were better because they started to get at behaviors, but we still didn't have good tools or assessments that really were relatable or formative in their feedback. And I certainly know when I was at Michigan sitting on clinical competency committee, I can't remember which milestone we were talking about, but basically had something to do with, balance and well-being. And we were literally having conversations like, well, so-and-so works out a lot, so they must be high on this milestone rating. And it was ridiculous. And so we didn't have a good framework for how to translate the concept, which again, these are the steps along the way. People were thinking about it, but we weren't quite there yet in terms of how do we translate this concept of competency-based training into assessment. And so in parallel to this, what happened was we went from a bad system of where the trainees were totally unsupervised to where they were oversupervised. And there's a lot of reasons for that and a lot of pressures for that, but they're both dangerous for patients. So if you're undersupervised, bad things happen to patients. If you're oversupervised and then you go into practice and suddenly realize all the things you don't know, and why is it so hard to do this operation that seems so easy when someone was using the right angle or, doing half the dissection with the suction, that's a different problem. And it also has patient harm with it. And so to that end, Lastly, I would say for those of us who have given board exams, we also, it's very clear there's like a very heterogeneous product that we had been producing. And I have had multiple examinees where I'm like, oh my gosh, that person's amazing. I'm going to go see where they are so I can hire them later. Or, oh my gosh, I need to make sure I never get sick and need surgery in that town. And so, but they check the boxes, right? Like, and so that was always very unsettling for me and felt really wrong because we didn't have the right tools to be able to say, like, I know that that person's not quite ready, but they like passed the exam. So that was sort of the framing of the problem. And as you can see, it's a big problem. It's a complicated problem, and it's going to have multiple nodes and threads that need to spin off of here to address it. So, you know, it's been a journey, and I just share kind of this is the journey of the American Board of Surgery's involvement in our kind of community of surgery along the way. And I'm not going to talk about each of these nodes, but it's just to say, like, these things, you know, this is 20 years of work, right, that has been going on. And it really has started going way back at the community level with the association, the American Surgical Association, for kind of first blue ribbon report that said, you know, Houston, we have a problem here. And there were a lot of ideas in that report, but we didn't do a great job of translating them forward. But there were a few things that came out of that sort of took spark and started moving forward. And I think that, you know, we've touched on some of the earlier things, but I think where things really pivoted was in 2015, when Competency by Design in Canada, you all were the first movers, right? You know, Richard Resnick, the Royal College, said, like, we are going to do this, and we're going to do this in a way that is going to force the issue. We're going to do it at a kind of a regulatory level, which never feels or sounds good, but I will tell you is the path forward if we really want to move beyond single institution sort of experimentation that doesn't actually take hold. Doesn't mean we get it right necessarily at each time, but it is an important sort of lever that we have in our education and training programs. So around that same time, the American Board of Surgery was like, we also are committed to this, but we're really sort of entering their exploratory phase. So they were sort of the fast follower and had an opportunity to see how things played out a little bit in Canada first. So the Netherlands really are the furthest along in this place of competency-based training, and that's really work that started at the University of Utrecht, Ali Tenkate, which I'll share how he's been influential in this space. And I would get these calls from Frank Lewis, who is executive director. I'd be driving down the road from my clinic in Fort Worth, Cancer Center Fort Worth, to back to Dallas. And when Frank would call you, he would never say hello or anything. And my phone, I still would get like chest pains when you call. I'm like, oh my God, what's wrong? And he's like, hey, how are we going to do this like EPA thing? There's going to be like 400 of them, and that's ridiculous. And I was like, okay, orient. And so then I'm like, well, no, Frank, there can't be more than 40. He's like, okay, I'm going to think about that. And then I get the next call. So they were thinking about it. And so they said, let's come and have a retreat and start talking about this. And that sort of started happening around this time after they went to the Netherlands. And a whole group of people flew to the Netherlands, and they went to see how they were doing it, understood what were the stumbling points, et cetera. And then finally committed to the assessment framework of EPAs, which is not the Environmental Protection Agency, but is Entrustable Professional Activities. And we ran a pilot and now have really, Joe Beiske has really driven this forward at the national level. And it's really exciting to see actually how well it's going. And I'll talk more about that. But again, it's a long journey to get there. It wasn't like, I think a lot of times the program director is like, oh, well, this is the flavor of the month, right? They thought this up and now we're going to do the next thing. But it actually has been a long and thoughtful journey. So this concept of trust, I love. And I think this Tenkate and others really helped me sort of put words to what I had always sort of thought about. You know, at the end of the year, your chief residents are graduating, like the best compliment you can get is, I would trust this individual to do my Whipple or to take care of my family members, right? Like that is it. And crystallized at the end of the day is, would you trust your trainees to care for you or your family members? And that's what I love about this assessment framework. What we do is high stakes, and the goal is not to go back to the quote good old days, which actually weren't that good if you were a patient, if you had someone totally unsupervised who didn't know what they were doing. But again, we have to then figure out how to impart progressive entrustment to our trainees. So we peel back the layers of support that we're providing with appropriate supervision. And as faculty, we're terrible at that. It is so hard to be in the operating room and not do the operation. And so we're really, really bad at that. And so that's the work that Gurjeet and I have worked on to do that faculty and trainee development piece, because it takes both people. So how do we get there? But that's the concept of progressive entrustment. And it's true not just in surgery, it's true in any high stakes environment if we're involved in training someone. Hiya, it is my daughter FaceTiming me, as I told you would happen. So trust. I think the best definition I've seen of trust is acceptable uncertainty. And this is my son. So for anyone who has a child that's gone through this transition, this is it, right? Like, have you seen them enough? Have they done okay in driver's ed? How have they done with you in the car? Do you think they're going to show up back at home that night and not kill someone else or themselves? Like, this is it, right? It is the same thing when you give trust to the trainee that they're ready. They're not going to harm the patient. They're going to call you when they need help. They know their boundaries, et cetera, et cetera, et cetera. I'm not totally certain about my acceptable uncertainty with him yet, because he really likes fast cars and he likes to go fast, but he's been pretty good so far, and he does take his little sister where we need him to go. But this is it, right? And this is where we have to get to with our trainees. And when we do have acceptable uncertainty or certainty, we have to be willing to give them a little more leash, because at the end of the day, my job as a parent is to make sure he's ready for independent life. And the same thing is true for our trainees, is that we need to make sure they're ready to be a safe surgeon when they go into practice. And you're not a fully formed thing when you finish training. You need to know when to call for help, and you need to be willing to call for help. And so that's a huge part of this. And that's what I think Tenkate has really crystallized clearly. If we look at what are the 4 conditions of trust, I love this definition. And this again is almost 10 years old now when this was published, but ability, integrity, reliability, humility. And the way this plays out when we think about our training environments is, what can they do? That's the most straightforward, right? But if you've never operated with them, you don't know that answer to that question. And so we can fall into this trap of, let me show you how I do it. So the poor trainees caught in 20 times hearing, let me show you how I do a lap chole. And they're like, yeah, I got it. So how do we have better visibility to ability? Integrity. Do they do what they say they're going to do? Are they honest? Are they truthful? When they say they're at the bedside, calling you in the middle of the night, are they at the bedside, or are they just looking at the chart and calling from home? Reliability. Are they consistent? Do they show predictability in their behaviors, or do they do this thing with this patient and this other thing with this other patient? And then humility. This is that knowing your boundaries. And I would say you can have the top 3 nailed, but if you are someone who's perceived as doing their thing and not alerting you and not calling you and not keeping you, as I say, as a leader, I'm like, I'm not going to micromanage, but I don't like surprises. So if there's something I need to know about, make sure I know about it, because I want to hear it from you and not, out in the hallways or from my boss. So same thing, like, do they know their boundaries? Will they call for help? If they won't, they're not entrustable. And I think that's super important, because you can have someone who's insanely talented, but if they are not going to call for help and they don't know what's the edge of their abilities, then they're not yet entrustable, because that's a critical part of being a surgeon. And we tell our trainees that all the time. I call my partners, they call me. That is a piece of being entrustable. So that concept of trust really then led to this concept of entrustable professional activities. And what I love about this, it's not the end of the rotation evaluation named by competencies, but it's workplace-based assessment, and it defines the work of a surgeon. And when we were doing our work at Michigan, we were working with a whole team of people and with our residents, and we were like, we need an image for this. And so we're like, okay, it'll be the handing over the scalpel. And the residents on our team were like, absolutely not. You're not trusted when you get the scalpel. You can give the medical student the scalpel. They're like, you're trusted when you give us the right angle. And we were like, oh yeah, you're right. Like, and how often do we do that? So that was the handing off of the right angle rather than the scalpel as the concept. They still don't, we were like, but you can also do a lot of the operation with the suction device. But so I think this idea that the EPA, the Entrustable Professional Activity, is this discrete element of surgical care that our faculty can relate to. They no longer need to even know what the competencies are. If you ask me, you know, would I trust a trainee to evaluate and manage a patient with pancreas cancer, I can immediately say, okay, they're entrustable in the preoperative phase of care. They can interpret the imaging. They can develop an operative plan. They're not yet fully entrustable in the operating room, and they're partially entrustable post-operatively. Like, it's just what we do every day. It rolls up all the competencies and milestones, right? There's a whole bunch of things mixed in there, but I don't think about it in the individual parts. I think about it as the whole. So now our faculty can think about the whole. They don't have to worry about the individual parts. Someone else does, which we'll talk about, but they don't. And again, at the American Board of Surgery, we have thought about this and crystallized this assessment framework as a floor and not a ceiling. So it's not that this is all they're going to do, these EPAs, at all, but it should allow us to be able to say to the public, to our patients, every, you know, board certified general surgeon can do these things. Many can do many more, but at least everybody can do these things at this level. And so that's the way that we've approached this. And it's anchored in trust. And again, when you change it to what can they do to would you trust them to do this on your friends and family, it really does shift and leads to better feedback and a different sort of way of thinking. So again, this concept of first mover or fast follower, I think, you know, clearly you all have been the leaders in this space. And I was invited to the CHPBA a few years back, and a lot of conversation there about some of the struggles that have come just due to the absence of tools, truthfully, and analytics and implementation, not around the construct of the concept, which has been incredible, but sort of like, how do we translate this into practice so it's actually feasible and it works and is not so hard to do? And Karen Brazel, this is a little morbid, but Karen Brazel and I have talked about this concept of the second mouse gets the cheese, which is a little morbid, but this idea that you in the fast follower space, you can be like, okay, we want that works. Like the foundation is totally the same, but we're like, we had the opportunity to be like, okay, we must have a mobile application that we can give freely to everyone, and we must have analytics, because if we don't have that to give to people, like the poor program directors and programs are so underwater with all the things they have to do, it is impossible. And we have to make it be better for the faculty than what is current state, because the faculty just are not going to do it. They cannot do one more thing. So we've had really the opportunity to watch and learn from what you all have done. And so when we started, we said, we're going to start small. There's good and bad to that, because it made some of the implementation a little bit harder if you didn't do any of these operations, but to get the automated behavior, but it was good to start small. And we did a pilot across the country with these 5 EPAs. And there's this huge argument in the United States, at least, around what is general surgery. And we did not want to get trapped in that conversation. And so everybody agreed these 5 things, at least, were general surgery, and agreed that they happen frequently enough that we would have enough opportunity to assess them in practice. And so, you know, what is an EPA? The thing I love about this is that most of my faculty have no idea, and they don't really need to know. They just need to know what is, you know, the evaluate and manage a patient with pancreas cancer, or, you know, evaluate and manage a patient with gallbladder disease. You fill in the blank. So that is what the first step of developing these. There's a lot of work behind developing these. If they're done well, is, you know, what are the functions of evaluating and managing a patient with gallbladder disease or an inguinal hernia? What's the scope of what we're going to look at? Then it is mapped to the milestones. We still have to report to the ACGME on our milestones. So they are under the hood, I like to say, but my faculty never have to look under the hood. Our program directors and coordinators do, but the faculty don't, but they're under there. And we make sure that all the EPAs represent and cover all of our milestones. And then importantly, you're going to write the anchors for behaviors that map to the different levels of entrustment. What are those different levels of entrustment? I will fully confess that I actually don't love this scale. I like the scale that we've used for the Fellowship Council better. But regardless, the concept is going from limited participation to practice ready. Direct supervision, indirect supervision. And the Fellowship Council are two middle one that we go from direct supervision, because it's a fellow, to indirect supervision on a more straightforward case, to indirect supervision on a more complex case, to practice ready, because that is sort of the reality of how people make progression. Either way, doesn't matter. There's behaviors that anchor to each of those. So I think importantly, what is the entrustment scale not? Because there was a lot of confusion in the early days of EPAs for us. I really was a loud vocal person around, we cannot let this be just the same renaming of our tools with EPAs. And that was what we were seeing. People were like, okay, we're going to have an EPA for putting in a central line, and an EPA for doing an appendectomy, and an EPA for this, and an EPA for that. And then we're going to be 600 EPAs, and we're just going to change the name to EPA. And that's not what it is, nor is it just a generic autonomy scale. It is hard for surgeons because we really like lots of like objectivity, but the reality is even OSATs and all of the forms we have, unless you do at least like 20 to 50 of them, they don't have reliability and validity. And it's just impossible and unrealistic that you're going to get people to do that. And when I was here 8 years ago, I had the opportunity to drive across town. Maybe it was to Sunnybrook. I'm not sure. I met with orthopedic surgeons who were just rolling things out at that point. And they showed me their forms, and I was like, oh my God, your faculty will do that? And he's like, yeah, not so much. So it's like this very long form thing. And I was like, oh my God, like that's never going to work in the United States. And so again, we had the opportunity to sort of think about like, how can we do this? It's uncomfortable. We like those long forms because they feel objective, but the reality is that it's very challenging. Because you have different types of operation, different complexities in the workplace, Hawks, Dove assessors, et cetera. You can't do just a couple checks and then say good or bad, right? You have to have a huge body of data to make that decision. So we really went with the micro assessment, but with these behavioral anchors. You're not going to see all of these things every time, but you're going to hopefully anchor on some of them. And it creates this shared mental model of what do we mean by indirect supervision? What do we mean by direct supervision? With the goal of then providing feedback that's anchored to those descriptive behaviors. And so that's the faculty development piece rolling out, and the trainee development is it sort of cues people, okay, what did I see in that case? Okay, I saw mostly you look like this, or mostly you look like that. And then it gives them some guidance to give better feedback rather than like, great job, or, great hands. That's my favorite. I don't know what that means. So just then I think this gives, really importantly for our trainees, the idea is these behavioral anchors give the trainee a roadmap. Like they're just sort of left guessing, what does indirect supervision look like to Dr. Curreri? Like, what does it look like to Dr. Minter? What is it, So the idea is that going into the case, they're like, okay, well, if I want to get to this next level, I need to focus more on this, using two-hand coordination or, whatever the case may be. So it gives them some guidance as well for the first time of how to show up and what to do. And again, they're not a checklist. EPAs in the United States are not assessed with checklists. It is workplace-based assessment that then is multiply iteratively assessed, multiple contexts, multiple faculty over time. And then we roll that up into a big picture with our analytics. So the pilot rolled out over 2 years across, I think it was really well done, all different kinds of programs, community, academic, big programs, small programs, high resource programs, low resource programs. And it was really designed to figure out what is going to be critical in the actual rollout. Where are the barriers? What are the gaps? And people had to develop their own tools. So we have a really fantastic software development and analytics team at UW. So we developed an actual app, which I'll show you some of the data from that. Other people were using Google Docs, all sorts of things. And it really helped clarify what our necessary requirements were going to be for an actual national rollout. And that was really the purpose of it. From there, we developed the 18 EPA. So back to Frank's, there's going to be 400, maybe 40. We got down to 18 actually. And this is really important. This is not everything a graduate's going to do, and you can't assess everything in the workplace. For EPAs, you have to be able to assess them multiple times, multiple conditions, multiple people. You're hopefully not going to do that with the emergency airway, right? Doesn't mean it's not critical, but that's probably going to happen in the simulation center because you're not hopefully doing 100 emergency airways with every trainee. If you are, that's a different problem. So we had to pick things that were done frequently. There are some things on here we expect to fail, but they wanted thyroid, parathyroid disease, for example, because in the United States and a lot of places, that's in otolaryngology and not in general surgery. And so there isn't going to be that opportunity, but they felt like when they looked in practice what general surgeons were doing, a lot of them are doing thyroid and parathyroid surgery. So they wanted to try to drive through the curriculum to see if they could force people to be creative about how to get those experiences. So we're going to see how these all play out. But I'll show you some data that most of them, with the exception of pancreatitis, are actually performing reasonably well. So I think going back to Tinkade's work, I think this framework really works. So if we think about the formative assessment that in the workplace that we use these EPA micro assessments for, which we do on our app, it literally takes 45 seconds to do, and I'll show you just a quick video of that. We make these decisions all the time. When the resident calls you in the middle of the night and says, your patient's here in the ED, this is what's going on, blah, 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 blah. They give you their plan. In your head, you're like, okay, is what they're telling me truthful? Is it what I know about my patient? What happened the last time the resident called me from the ED? Did they have a good plan? Are they generally reliable? Is their plan sound? And you immediately make a decision. Sounds good. You go back to sleep, or well, I might do this thing or that thing, or you get out of bed and drive to the hospital, right? Like that happens in your head. And that's that ad hoc moment to moment entrustment decisions that the faculty are making in real time every day, all day long. But then this summative entrustment piece, this is where we've really struggled, which is how do we, and this is from kind of what they do in the Netherlands, but how do we roll that data up and make those higher level decisions to say, okay, this trainee is ready. We've seen them enough in enough circumstances across enough faculty to say they're ready for that next level. So that's the piece that we've really spent a lot of time thinking about. And that really, in our framework, is the job of the Clinical Competency Committee. And going back to that, they work out a lot. They must be good on this milestone. Like we need better data in that space. And so I really think, is it perfect where we are? Absolutely not, but it is so much better than what we've had historically. And I'll show you some examples of that. So the analytics are critical. And that's where I'd say my team has spent a whole lot of time thinking about this. So what does this look like? And I will apologize because our developer, who is not a surgeon, didn't totally understand and mismatch these, but we should, oh, there it goes. So this is an example of our app. We have all of our fellowship app EPAs in here as well, so that we can do the general surgery ones or the fellowship ones, depending on what service. So you can see, and we have the endocrine EPAs in here as well from the AAES. So if you pick the EPA, we have favorites now where you can just have your little favorite list. So it's even way faster. So I have, 5 things I do on my list that I grab. They fill it out. We start it with the trainee, ideally, but it can go either way, but both people have to assess. That self-assessment has been fascinating to see that data. And so you can see the anchors, you go back and forth, you're going to pick pick the level, and then they submit it. And it will then come, and you can see it's very easy to scroll back and forth. Okay, they look most like this level. We're going to pick this level. In our app, not in the simple rollout with the ABS, but in ours, it's mandatory to provide the feedback. And most times people actually provide useful feedback. Not 100%. We got a couple rogue agents who will put like a period so they can get out of it, but very rare, and we shame them when they do. So it generally, the feedback is actually very helpful and succinct, and the trainee has to provide feedback too. And I always look at the trainee's feedback. It's very informative for me to see like how much insight do they have and how self-reflective are they? Did they also put something thoughtful, or did they put something just to get out of it? And that has been super helpful for me to have a sense of how well they know where they are. So then it goes to the faculty member. They get a text notification. You have an EPA to complete. You go in, you do your part, same thing, you provide your feedback, and then you can go back and look at To move to the next one. And then you can go back. This is where you can see what they put, et cetera, and see their feedback. So if you initiate it, you can see their feedback after you do it, or vice versa. It works in either direction. So this literally takes like 45 seconds to complete. I always initiate because I do it as I'm walking out of the OR, or otherwise I'll forget later. We have other faculty who wait for the trainee to send it to them. But it overall works very well. I would say this is critical though. And when we did the pilot, we at our institution did a great job collecting the data, but it sort of went into this black hole. And so it was useful in the moment, and it led to better feedback in the moment. But the value beyond that, and when you want to think about the sustaining of this over time, is that it has to have perceived value for everyone who's participating, and the EPAs can't go into a black hole. They have to be actually useful. They have to actually lead to improved autonomy and opportunity. And that's where the enabling analytics are just absolutely critical to success. There are different stakeholders in this, and you have to think of all of them because they all have different needs and interest in this. And if you don't bring value for each of these stakeholder groups, it's not going to succeed in a broad scale rollout. And so this is how we have thought about it in terms of the tools must meet the needs of all of these folks, and they have different needs. So if we look at the resident lens, they appreciate that in the moment sort of form of thing, but they kind of were like, well, we could do this if someone would just talk to us and give us some feedback at the end of the case, like, that would kind of serve the same purpose. So it has to be the roll up and the feedback. So they find the feedback in our application, it's required 100% of the time. They get much, much better feedback. But then being able to see it at a higher level and use that data at a higher level is hugely valuable. So this shows you, this is a dashboard they can easily log into, preparing for a case. So this is gallbladder disease, 3 phases of care. You can see, not surprisingly, workplace-based assessment would by far get the most data in the intraoperative phase of care. We've done a lot of research looking at the differences by gender of self-assessment versus faculty assessment. I won't show you all that today, but what I would tell you is, interestingly, in our environment, and we've repeated it now with many more assessments, what we see is our faculty are not assessing by PGY level, our female trainees and our male trainees differently. There's no significant difference from the faculty assessment. However, on the self-assessment data, the women are at every PGY level consistently underestimating their ability as compared 1-to-1 to the faculty assessment as the gold standard. It is not surprising. It's how we are socially enculturated. It's around, how women are supposed to show up and how they're supposed to talk about their abilities, et cetera. But you can imagine it does lead to a difference in how we give feedback. If one person needs really to have more confidence, how we give that feedback is going to look different than someone who's a better self-assessor. And to be very fair to my male colleagues, the male residents were not overestimating their abilities. They were just much more accurate. They were much more, like, almost exactly aligned with where the faculty were putting them, whereas the women were consistently under. We haven't had enough data to look at this through the lens of underrepresented other populations. I would guarantee you it will look the same and probably even worse, frankly. And so now that we have national data, we'll be looking at that question at the national level. But it does inform then your faculty and resident development strategies. So this is a great example of a trainee. Faculty, you can see the red dots here in this middle section are above the blue dots, right? This happens to be a female trainee, one of our very best senior residents, but she consistently says that she's lower than where the faculty would place her. Importantly, you can see the dots are moving up to the left. This was in the pilot when we had an extra level of entrustment scale. But overall, you can really start to see, like, she's making progress and she's moving up to that practice ready, can teach others sort of level with this data. You can see if you hover on the dot, you can pull up the feedback. So that's really helpful for the hawk and dove situation. The residents all know who we are. And if they have like an outlier dot and they hover on it and they're like, oh yeah, that's Dr. So-and-so, I'm not going to get too worked up about that. They say everybody's terrible. It is very useful to sort of just kind of level set and not get so worked up about, this one like outlier. But a lot of times those hawks give some of the best feedback, right? Because they're very succinct. They're like, you need to work on this thing for me. to get to that next level. So again, it's rolling up that data, and hopefully they then go to this next one where you can see all the feedback. This is sort of an older example, and we've done a lot of coaching now in our faculty to give better feedback. As you can see, it's highly variable. But one of the things we've told our faculty is in that feedback, you need to tell them, what do they need to do? One thing, what do they need to do next time to get to the next level of entrustment? Just pick one thing to move from here to here. How do you get there? And so when they look through all this feedback, the idea is that they can come to that next case and say, I've heard from multiple people, oh, by the way, I've done this operation 40 times, first of all, so you don't need to show me how you like to do it. And, but this was the thing I am working on. Like, I'm really working on this thing because I've heard it from a number of faculty. And then hopefully you can hone in on, okay, well, let me help you with that thing. Like, let's really work on that in this case. That's for a resident who's really engaging with the data. Not all residents do. But if you're going to get the maximum out of it and move forward more quickly, which is the goal of this work, then that's where the data can be super useful. The faculty, interestingly, like this approach even way better than our residents. They find it's very intuitive to complete the micro assessments. They also have access to that same dashboard. However, they're super busy and they're just going into the next case. So it's very unlikely, frankly, that they're going to log into the dashboard and be like, oh, I see that you need to work on two-hand coordination. So we tell the residents, like, well, they could see it too. I'm like, it's not their responsibility. They already know how to do this operation. So you need to come and tell them. Now, if you tell them and you do that work and they're not willing to engage and talk about it, then that's a faculty development thing that we need to know about. So we make sure the residents know, like, we feel like that's their responsibility, and they need to be empowered to be assertive if they're doing that work to bring it to the faculty. This is an example from Brunessa Lindemann, back to, work with really smart people and learn from them. This is what they developed for the endocrine assessment. And this is something we're building into our app, which is that nice snapshot for the faculty. The faculty might do this, right? They might look quickly in the app and say, oh, where were they? Where was their sort of last summative entrustment level? Are they at 1 or are they at a 4, right? How much, going in that case, how much autonomy should I be anticipating I'm going to give them? And so this really speaks to that issue of not always starting at ground zero, to have visibility to what they've done with your partners, even if you haven't operated with them a lot. So this is a super useful aspect of this tool. We are huge, we are spread out, everybody is facing that, and it makes it harder to know our trainees. And so it really disadvantages them, because it used to be you worked with a small group of faculty over and over, and you knew what they could do or what they couldn't do. And that really is something that's a challenge with our current residency design. So again, just some more, when we think about that CCC, for us, that's the Clinical Competency Committee. What's the roll up? So this is just showing the first 5. We have it for all 18 now. Our CCC comes together. They have visibility. They can drill down on each of these graphs. They can again look at the feedback as we showed earlier. This gives the whole big picture, and you'll see over here on the side, kind of there's some of these predictive analytics. So it's showing, how many do you have for each of these. If we look here in this intraoperative bucket, so there's 21 assessments. It's showing the estimated entrustment level with the confidence interval. And obviously, it depends how many assessments you have in terms of how much validity you're going to give to this in the CCC. And it's ultimately the CCC's job to say, okay, we think based on all the other information that we have and know about this person, that we're going to say they're at whatever level, level 3 or level 4, or they might say, oh, well, it says 4, but we have these other concerns. We're not quite ready, or they don't call for help, or they don't do this other thing. We're not going to actually move them all the way up yet. And they're going to provide that feedback. The program administrators still have to report through web ads to the ACGME on the milestones, and super important to make that easy for them. And again, as I said, the milestones are under the hood of the EPAs. So one of the first reports that our team developed was this mapping, and uses Bayesian analysis to project the estimated milestone levels with confidence interval, with the number of assessments and the number of assessors. And so, as to look at a couple examples here, if we were going to look at the milestone of PC2, which again, none of my faculty know what that means, patient care 2 and what, milestone that is, we had 32 assessments from 13 assessors. That's pretty good. Lots of different faculties' perceptions, 32 assessments. You can feel pretty good about that 4.31 assessment. Versus if we look down here, 5 assessors, 5 assessments, in terms of the general surgery consultation and Prof 2, we're going to take that with a little bit more of a grain of salt and probably give that one a little bit more time before we might, move that up. So we use this as a starting point in terms of our milestone report, and then our coordinator can really easily, and it gives us so much more data and so much better data than we've ever had before for our milestone assessments. It just starts the CCC with a lot of data and a lot of sort of like, here's our starting point, but then the CCC can adjust, up and down based on other pieces of information they have. It's critical to drive engagement with analytics. And so we've done this by giving feedback to our divisions. We've done a number of levers, and I'm happy to speak to that. But we have provided feedback so people know, oh, you haven't, the division chair can say, oh, you've never logged into the app. Guess what? You can't do micro assessments if you never log in. So they get data on how many times people respond, don't respond, and they get this information. It's been very important, very successful in terms of driving engagement and decreasing non-response rate. Division chair gets this data. They just like they bring their RVU data to their division meetings, they bring this kind of data to their meetings. And again, this gets back to the who are the responders, who are the non-responders. And now we've added a column of who's logged into, when was the last time you logged into the app? They get a third column with this now. And so I see the emails, they're like, so Dr. So-and-so, I know you were you were on call last week and you haven't even logged into the app. So like, get on it. This is just to show you how it's gone. This is our last academic year. So this is our institution. Obviously, I'm a champion, and so we have strong engagement. But I think the great thing to see here, and what we've learned, and it's played out nationally as well, is that it is both a 50-50 thing. 50% of the time, the trainees initiate, 50% the faculty. But you can see that aside from the severe acute pancreatitis, which we don't operate on, which we said, but they felt like, again, like the surgeon's going to be called on the community hospital to be the first responder to those patients. So they wanted to put this in. That one may not survive, but the rest of them, they've all had some assessment, and some of them have had a lot of assessment. We apparently have an epidemic of appendicitis in Madison, Wisconsin. So there were like, this is only the ones that got assessed. So God knows how many appendices we took out in our small community. So I think just going back to kind of how do we get to that ultimate goal of increasing autonomy? I think that, this is the stepwise progress, right? We needed an assessment framework that people could trust. Then we need to do faculty and resident development. Faculty no longer have to worry about the milestones, and they love that. And we've tried to really minimize our end of rotation evaluation to take that pain point away as we feel more confident with our EPA data. And the only way that happens is that analytic piece of giving the data back, showing how we're using it, adding that value to our overall system so people will continue to engage. This second academic year, we've seen continued engagement, and we've been able to back off a lot of our sort of hand holding as we've gone. So it's sort of taken hold and become more automated as we've gone. And I think I really applaud Joe Beiske of saying that, we're not taking a heavy-handed approach on this. The goal for the rollout is progressive engagement. And there's only like 5 programs that haven't done a single EPA. And so we're getting there, which is pretty incredible in 2 years, frankly. So just in closing, I think, you always have to come back to the why and make sure that you're actually making progress on the why, because you can get really lost along the way and miss that. And I do think we're not there yet by any stretch of the imagination, but I do think we're making progress, and I do think people are finding value. So thank you so much. It's really, again, privilege and honor to be here, and happy to take any questions. There's time.
Thank you so much, Dr. Minter. I think we're getting a little bit short on time, but we certainly do have some opportunity for questions, if that's okay for you. So we can start with folks in the room. Yes.
Yes, it's a lot to pack in.
I was just going to say, Andrew Howard from Orthopedics. One of the drivers of faculty disengagement from assessment now is the increasing perception that it's rather meaningless if a resident can't fail because it's 2000.
That it's meaningless if what?
If a resident can't fail anyway, because it's 2025. And I think we've always had this behavior of give them a 3, there's too much paperwork otherwise. But do you have an approach or a comment on that? And are you facing residency programs that, because they're designed to put everybody through, might put the wrong people through occasionally?
Yep. It's a great question. And I think it's one of the things we learned actually, because we heard some of that feedback loud and clearly from our Canadian colleagues. By having the micro assessments, my message to the faculty is we're going to do it every single time, right? Like every single time we're doing an assessment, and trying to get the residents to understand, like, you can't cherry pick the cases. That's why having both people be able to enter them is critical, and having it be really easy, because if you're just waiting for the resident to serve up the ones that they like, guess what happens? And that's human nature. I would do the same thing, right? Like, oh, that case was terrible, I'm not sending an EPA for that one. Like, so because the idea is to have a ton of data to see the progress over time. What we've seen, and other specialties in the US have seen, is that we get much earlier signal when someone's struggling now. And the problem with our old system was you didn't see it until so late, and then people felt this obligation. But also for the poor trainee, they're labeled, then they don't get opportunity. I mean, it just becomes this terrible self-fulfilling prophecy. So our hope, and what we are seeing some sign of in the programs that do it really well and really get that good engagement, is you get the signal much earlier and you can intervene much earlier. And so that's the hope. But if you can't have a long checklist, or have it be that it's only when the trainee sends you the EPA that you do it.
Rebecca, thanks. Amazing as always. The question I wanted to ask was, obviously the person who completes the EPA, but from the faculty side, is identifiable. And you mentioned hawks and doves. And so how do you get the trainees to understand the hawks and doves phenomenon, that everything equals out? And how do you, there's always concerns from the faculty that if they give an EPA or an evaluation that is critical, that can then come back to them in other ways, particularly in the training evaluations of teachers.
Yep.
How do you address that, and how do you build a culture where those kind of concepts are understood and vocalized? Yep.
No, I definitely heard that as well. And I think a key thing for us, again, is that do it every time, and looking at that whole array of feedback. And what's interesting is there's a lot of faculty and trainee development. And I always say both, because you have to develop both sides of this equation. And what we've seen, which is amazing, is that if you train people to give the feedback according to those anchors, and take out the adjectives, right? Like if you just train yourself when you're giving feedback to take out adjectives like great, terrible, whatever, like, just, I saw this, right? And you need to do this next time to make progress. Like, that is huge. And if you do it every time, what many of our trainees have said, they've come back and they're like, yeah, you gave me level 4. I wasn't at level 4. Like, look, that anchor is not what I did. I'm like, I was at level 3, and I needed to work on these things. So it becomes this like back and forth training each other if you make it non-emotional. And when they can see that whole array, and they can see it's a scatter plot, and there are hard cases and easy cases, and there are hawks and there are doves, like they get it. Like, it is going to be a scatter plot, but as long as if you draw a line through that, you see like they're making progress. Or if they're not, they're like, gosh, I'm not making progress. What do I need to do? It really does help solve that issue if you do it every time. If you only pick and choose, then you're going to fall into exactly what you said.
What, just, we're gonna get to Dr. Gladdy in just one second. I just want to go online for a second. First of all, there's almost 100 people online and all
Oh.
kinds of clapping and
Oh.
positive
Thank
emojis
you.
and things flying there that you can't see. So I just want to let you know that. But a question from Dr. Rutka. He wants to know who performs and who is paying for the detailed analytics in surgery programs in the US, and is it standardized?
Great question. So we are still, so there's 3 applications in use right now in the US for general surgery, and the ABS is just actually going through an RFP right now to select another vendor that they're going to be used. But one of the things we learned in the rollout is that the ABS needs to provide the tools and the standards for that assessment. So we, again, developed our tools, but our tools have helped informed then what the ABS's tools look like, whether they use our tool or not. There's another tool called Firefly that also is out there. So we basically said, here are the necessary requirements. If you're not going to use our tool, you must have the same requirements so that you can upload and feedback the data, et cetera. And it is an investment, but that's where, again, going back to the top-down piece, like the only way this was ever going to happen was as if there was that investment at the highest levels to make sure the tools were available to everyone. Yeah.
Excellent. Maybe we'll go back in the room. Dr. Schwartz.
Thank you so much, Rebecca. Such a wonderful talk and important for us. Did you have any screening process, at least in the beginning, to prevent any effect on the residents? Because some of the feedback can be very harsh. So how was the program director seeing everything before they release it to the residents, or it automatically goes to them?
It automatically goes and it comes back in the app. And again, there's a lot of faculty and resident development as you roll it out, right? Like, what is this? How are we going to get the feedback, et cetera? And I think, and it hasn't been harsh, actually. And the residents are really smart. Like if someone is going to give very direct or harsh feedback, I guarantee you they've also heard it face to face. Like, it's not like a surprise to them. But that gets back to that automating the behavior, doing it every time. So that again, and helping them understand, like, if they want to be better and they want to grow and they're giving their own feedback, like I said, I can always tell, and I tell them, I'm like, I'm going to look at your self-assessment. So make sure that you actually put some thought into it. And if some people are like, I'm like, whoa, we were in 2 different operations, that's a problem. And that gives me insight of a different thing we need to work on together.
Yeah,
I'm going to make a
one
very
more
brief
question.
comment.
Yeah, absolutely.
I love this because objective and constructive feedback is what the residents need from us, not judgment.
Yes.
And then it teaches the hawks how to circle, because what your framework allows us to do is to reinforce to ourselves, our job is to train people to be independent surgeons.
Mhm.
And we all know who lets the residents operate. We know the ones who don't. So I think this is a very good faculty development tool for everybody.
And I would just say, to be fair, I think sometimes the hawks are better than the doves, frankly, because they actually give very focused and constructive feedback. And even if it comes through versus like, oh, you're wonderful, and, et cetera. So I don't think hawks are bad. I think you need both, right? Like, and it's helping both of them figure out how to give feedback in a way that it's heard. And that's the faculty development.
Excellent. Yep. Well, listen, I think on that note, it's pretty obvious. I think we need to have you back. And this is to be continued. So we're extremely grateful to have had you,
Thank you
this
so
morning
much.
and to have you join us. And I just wanted to present to you a small token of our appreciation on behalf of the Department of
so
Surgery
much.
at U of T. And
Thank
thank you so
you.
much for coming. And thank you everyone online for joining us. Look at all these clapping and cheering. It's
Thank you.
and in person too.
Thank you so much.
Awesome. Thank you so
Thank
much. That
you
was
so much.
wonderful.